Thank you very much. So in this short introduction, I will just address two questions. First, what is the prevalence of sleep disordered breathing in the general population? And second, how can we diagnose sleep apnea? So it's mainly for cardiologists who may be less familiar with sleep apnea than pulmonologists. So when we think about the prevalence of sleep disordered breathing, we usually refer to this study that was performed in Wisconsin and published in the New England Journal of Medicine in 1993. So in this study, they took people working for the state of Wisconsin, aged between 30 and 60 years of age, and they had a full polysomnography, and they found that about 27% of these people had an HI above 5, and 9% of the women. When they focused on sleep apnea syndrome, which is not only sleep apnea during the night, but also daytime sleepiness, then they found that about 4% of the men and 2% of the women had this syndrome. The problem is that this study was performed mainly in the 80s, and the technique that we use now to record sleep and sleep breathing is quite different. It was still paper and pen, and right now we have more digitalized recorders and also different criteria. So we thought it was important to reassess the prevalence of sleep disordered breathing in the general population. And to do so, we took the HypnoLaus study, which is a cohort of people that were randomly selected from the general population who participated to another cohort called CoLaus. So they're representative of the general population of Lausanne. They're aged between 40 and 85 years old, and they had a full polysomnography at home. Polysomnography includes electroencephalogram, electrooculagram, and electromyogram to define the sleep structure, the different sleep stages. We also had respiratory parameters such as nasal pressure, chest and abdominal movements, and pulse oximetry. We had leg EMG to see the people who move their legs during the night, and unfortunately, only one lead of EKG. So these people were coming to our sleep lab in the late afternoon to be equipped with all the sensors, and then they would return home, sometimes with the public transportation. You see here all the wires on this poor lady. And they would sleep at home, which is good because it's their usual sleep environment. And then they came the next day to bring back the device so that we could download the data and analyze it. So overall, we had 2,100 people. Mean age was 58 years old, about half women, half men. BMI slightly above 25, and the mean Epworth score, which is the sleepiness evaluation, was 6.2 on average, which is more or less what we expected for a general population. It's considered abnormal above 10, so 11 and more is considered abnormal. Neck circumference, which is a risk factor for sleep apnea, was 36.9. So this was quite a surprise to see these numbers. So if you take a threshold of apnea-hypopnea index of 5 or more, what the Wisconsin sleep cohort study did, most of our patients, most of our subjects had some sleep apnea, like 83% of the men and 60% of the women, which is much more than what we expected. And if we had a younger population, probably it would be lower, but in these 40 to 85 years old, this is what we found. And if we take an HI above 15, which means moderate to severe sleep apnea, we still have about half of the men and almost a quarter of the women who have this type of apnea, and 22% of the men and 7.6% of the women who had even severe sleep apnea, which is much more than what was reported before. You see that there is constantly a difference between men and women. And if we focus now on the women only, and we divide them in premenopausal and postmenopausal women, you see that premenopausal women had much less sleep apnea than postmenopausal women. And this is a huge difference. Of course, the age is different, but this does not account for the whole difference. Why do we see that? Probably because premenopausal women, when they accumulate some fat, it's more on the lower part of the body, whereas after menopause, it tends to be more truncular obesity with a larger neck, which looks more like a male obesity, and obviously truncular fat is a risk factor for sleep apnea. Then we also looked at the sleep apnea syndrome, so not only sleep apnea during the night, but also an Epworth score above 10. We saw, obviously, the numbers are lower, but still 18% or 19% of the men and almost 11% of the women have sleep apnea syndrome in this cohort, whereas it was only 2% of the men, 4% of the men, and 2% in the Wisconsin. So why do we have such big differences? I just compare here a few points between the two cohorts. So of course the number is a bit larger. Our population is slightly older, but the mean age was not so different. So probably that does not explain the big difference that we saw. We did it at home, they did it in sleep laboratory, but this shouldn't impact too much on the sleep apnea prevalence. We used the recent American Academy of Sleep Medicine criteria, which defined a hypopnea as using a 3% desaturation. So a hypopnea should induce a 3% desaturation instead of 4% here. So it was more restrictive here, which can explain why they have a lower prevalence. The sleepiness was evaluated in different ways, but also a big difference was the way we recorded the nasal. We used this nasal pressure to record the breathing, and you used a thermocouple or Untitled CO2, which is less sensitive for hypopnea. So I show you here an example. This is about 3 minutes of a recording. You see here nasal pressure signal, and this is the thermistor that they used. So here we see much more subtle variation in the breathing compared with the previous thermistor that was used in the other study. So probably we see much more hypopnea using the currently used technique in the sleep lab now and in the polygraphy than what was used before. Hypopnea definition is very important because you see here that the largest proportion of the respiratory events that we score are hypopnea, and only a minority is apnea. And when we compare men and women, it's also interesting to see that women have more hypopnea and respiratory effort-related arousal, which is a mild form of hypopnea, compared with men who have more full apnea. So it's a little bit different between the genders. Okay, so now what is the prevalence of sleep disordered breathing in heart failure patients? I just show you one study, a very recent study published in a very good journal just a few months ago. And they took 6,800 patients with a left ventricular ejection fraction of less than 45%. They determined the prevalence of sleep disordered breathing according to an AHI threshold of more than 15, which means moderate to severe sleep apnea. And they found very important numbers here, 36% of the women and 49% of the men. So this is even more for the women, at least, than what we found. And I don't think that AHI is the best metric to judge of the severity of sleep disordered breathing in heart failure patients, because if they have Cheyne-Stokes breathing, for example, Cheyne-Stokes breathing has an oscillation rate of about 1 minute as a definition, whereas sleep apnea can last only 10 seconds, so you can have several apnea during 1 minute, and if they have Cheyne-Stokes, then of course the AHI will be low, despite the fact that they will have severe sleep disordered breathing. Then they also analyzed in heart failure patients the prevalence according to the gender and to the age. And you see here, as expected, that the prevalence increases dramatically with age and that men tend to have more sleep disordered breathing than women. The main weakness of this study is that they couldn't make the difference between central and obstructive sleep apnea, which is very important for heart failure patients. Now another interesting graph is this one. You see here the left ventricular ejection fraction and here the prevalence of sleep disordered breathing. So we have a negative correlation between the left ventricular ejection fraction. So the lower the ejection fraction, the higher the prevalence, which is quite expected because it may generate central respiratory events. So now, how can we diagnose, the second question, how can we diagnose sleep apnea? So basically, we have 3 different types of devices that we can use. Oximetry or apnea link, which is oximetry plus nasal pressure. Respiratory polygraphy, which focuses mainly on respiratory parameters that can be done ambulatory at a pulmonologist office or in a sleep lab. And polysomnography that we just talked about, which is the gold standard to diagnose different types of sleep disorders. So when we have typical events, like obstructive apnea here. You see no flow. There is still movement in the thorax and the abdomen that go in the opposite direction. You see here desaturation. Things are very obvious, and polygraphy can really diagnose them easily. When we have central apnea, like here, so the difference is that there is no thoracic and no abdominal effort. This is very obvious also. Polygraphy can perfectly diagnose it. And even if we have chain strokes, you see here beautiful chain strokes, about 1 minute period here with severe desaturation. However, when you have more subtle events, sometimes oximetry can be completely normal. And in some events, even polygraphy, you see only mild variation. Here, this is inspiration, expiration, and you see a flow limitation here that goes back to normal here. This is a normal inspiration. So you can suspect that something may happen, but you cannot score anything because there is no desaturation. So in these kind of cases, when someone is very sleepy, but you don't see much on the oximetry or polygraphy, then you need to do the polysomnography, and this is exactly the same part of the recording, and you see that there is an arousal here, meaning that the increase in the respiratory effort that was here generated an arousal, which may disturb the sleep and generate sleepiness during daytime. So sometimes polysomnography is still needed. Okay, so do we have scores that can allow you to decide whether you want to send your patient for a formal polygraphy or polysomnography? This is especially important because in Switzerland, only pulmonologists and sleep labs are supposed to do these polygraphies, and ENT now also. And so it's important to really decide who should be sent for this type of investigation. And the Berlin questionnaire is an option. So it has 3 different categories. One is snoring, one is fatigue, and one is about BMI and hypertension. So if the patient has 2 out of 3 of these categories that are positive, it's considered at high risk for sleep apnea. The problem with this score is that it's pretty complicated and not many clinicians use it because it's time consuming. Another option that is more simple to use is the stop bang. So it's 8 different items that you see here, and each item is worth 1 point. And if you have 3 or more points, it's considered abnormal and at risk for sleep apnea. I think the main issue with this score is that it includes a lot of people, because if you're a man with a BMI slightly higher than 25 and you're tired, then you have to go on and go for a full sleep investigation. And when you look at this, this is a clinical study from Egypt. You have 92 to 99% of the people who are positive. So it's not very helpful. In the HypnoLaus study, so general population, about 69% of the people were positive. So it's not, you don't miss anyone, but it's not very discriminative. That's the problem. So we decided to make another score. It's called the NOSA score, based on the HypnoLaus cohort that will be published tomorrow in the Lancet Respiratory Medicine. So it includes 5 items. Very simple. Neck circumference, more than 40, gives you 4 points. Obesity, if your BMI is above 25 and below 30, it gives you 3 points. If the BMI is above 30, it gives you 5 points. Snoring, self-reported, gives you 2 points. Age above 55 gives you 4 points. And male gender gives you 2 points. So we tried to avoid subjective items such as sleepiness, because sleepiness can be due to many different things, and people will interpret their sleepiness in very different ways. So the only subjective parameter that we have is the snoring. So we tested it in our cohort, HypnoLaus, and compared it with the stop bang and the Berlin. And you see here that the area under curve, which is more or less the discrimination of this score, is above the other scores. And then we decided to validate this score in another completely different cohort called Epidemiology. It's a Brazilian cohort in which they did polysomnography in 1,000 people from the general population, and it performs even better with an area under curve of 0.81, and here it was lower. If you look at the negative predictive values here, 0.98, which is good, 0.90. It's a bit lower than stop bang because stop bang is highly sensitive, but the specificity is very low. So I think probably this NOSA score is a good compromise between high sensitivity and a good negative predictive value. If we take different thresholds to define sleep apnea, you see here moderate to severe and severe. Only for an HI of 5, which not many people use now, the stop bang is better than the NOSAS, but if you take 10 or more, then the NOSAS is better. So for those who want to use it, there is an app for iPhone or for Android also. It is completely free. You can use it, and it's very easy to calculate. So overall, sleep disordered breathing is highly prevalent in the middle to older age population, about 50% of the men and 23% of the women. Sleep disordered breathing is also very frequent in heart failure patient with a left ventricular ejection fraction below 45, so it's an important condition. To diagnose it, polygraphy is the minimal standard because it includes also a thoracic and abdominal band that will allow you to make the difference between central and obstructive sleep apnea. Then for those who are not pulmonologists or don't work in a sleep center, then the screening score can be useful. It can be oximetry, for example, or some scores that will allow you to decide whether your patient is at high risk or at low risk. For example, if you have someone with an atrial fibrillation, you know that apnea is a risk factor for recurrence of the atrial fibrillation, then maybe if you can screen these people and decide whether it's worth to go on and ask for a complete recording. So I would like to thank the whole team of HypnoLaus.